because I think a lot of students may not know you. Everyone, I'm great to see all of you. Excited to be with you today on our monthly meeting. I'm excited to introduce to you Dr. Dvora Davey. She's Associate Professor in Infectious Disease here at UCLA, and also and Dvora, I'm forgetting your title at UCT.
Honorary Associate Professor
Okay,
of Epidemiology.
Associate Professor at University of Cape Town, where she is based. Dvora has been living and working in Cape Town for numerous years now, and has a really well-established program there, and is, I think, a really fantastic example of what global health can look like if you want to be based in a global setting and still be tied to a U.S. academic institution. So Dvora is one of the leading researchers in PrEP among pregnant and breastfeeding women, and it does a lot of really interesting mixed methods that include epidemiology, qualitative implementation science to really understand how PrEP can be integrated well and the potential impact of it for preventing new infections among pregnant breastfeeding women. So really excited to have her with us today. She's going to talk through some mixed methods and leaning into some of the implementation science, which really is what applies to all of you doing more programmatic work, anything in terms of public health programming or anything related to interventions. The implementation science lens is incredibly helpful. So, Dr. Davey, I'll pass it over to you. Thanks for joining us.
Thank you, Kate, for the great introductions, and I'm happy to be able to be here with you today to talk about mixed methods. I'll make this an informal presentation, and so if you have questions as we go, please feel free to ask and stop me. We'll also have time at the end, about 15 minutes at the end for Q&A, and I'm curious to learn more about your projects and how you'll be implementing mixed methods as well. If my sound is breaking up, please let me know and I can turn my camera off. Can everyone hear me okay? It's okay?
Yes.
Okay.
You're good right now,
if
yeah.
If it gets worse, just let me know. I'm having some power problems here in South Africa. Okay, so we're going to talk about mixed methods, and Kate asked me to focus really on implementation science and some fundamental concepts. So the objectives today are really to define implementation science and mixed methods so that everyone can become familiar with the terminologies used. There's a lot of acronyms and a lot of terminologies that it's important to have a basic understanding of. Understanding the importance of mixed methods, implementation science, and dissemination of research, and to understand the concepts of implementation science, specifically outcomes, determinants, frameworks, strategies, and application of mixed methods. I'll give an example at the end in a recent study of mixed methods using implementation science in our work in South Africa. And so what implementation science seeks to do is to close the gap between what we know, and so what research has shown, and what we do, which is really called the know-do gap, as you can see on the right. So in this translation sequence, I really like this translation sequence as that we're all doing research in different areas of work. And really what we first want to look at, could a program or an intervention or a new drug work? So focusing on the big circles on the left, does a program work, and then making it work. And in that, over time, you have a pre-intervention studies that are clinical trials, efficacy studies that show, does it work? How does it work? And then effectiveness is really in a real world setting. How does the intervention or program work? And within the dissemination and implementation studies, you have really moving from local to generalized knowledge. There's exploration, adoption, preparation, implementation, and sustainment. So all of us really, even if you're working on pre-intervention or efficacy studies, want to see a sustained intervention or program being implemented over time. So this is really called the science to public health impact. We have what we know in basic science, and there's a gap in the public health impacts that we seek to reduce or remove through implementation and implementation science. Here's some terms and definitions that we'll be going over today. So dissemination is really the communication of tailored information to target audiences. Mostly this is through publications, but we like to also think about this as even me disseminating information to you today, giving presentations, doing posters, in conferences, conference presentations, even working with the media to get the word out, and to really translate what we're doing with our research. It's an inherent part of implementation, but it's not enough on its own. So really, we want to focus on more than just disseminating through publications, but also working with local groups to understand what we've done with our research. Implementation then is an effort designed to support uptake and sustained use of best or evidence-based practices. So this is really helping people do the thing or the intervention or deliver this evidence-based practice after you've found that it has been effective. And the effort deploys strategies to support implementation. So we can't just say that this intervention has been effective, but we really need to find what are the strategies that we can use to support implementation. So the definition of implementation research that I like here is a scientific study of methods, and including mixed methods that we'll talk about today, to promote the systematic uptake of research findings and other evidence-based practices into routine practice, and hence to improve the quality and effectiveness of health services. Other definitions: an efficacy study, as I mentioned earlier, is really looking at a very specific population in a controlled setting. So this is really an emphasis on internal validity and the extent to which a study establishes a cause and effect relationship between an intervention or a drug or treatment and an outcome. Effectiveness, on the other hand, evaluates intervention performance in diverse populations in real-world settings. So the external validity or the generalizability of the intervention is balanced with the internal validity, which is within the study. EBIs are interventions that have undergone sufficient scientific evaluation to be considered effective. So both efficacy and effectiveness studies. And I've seen people use these terms interchangeably, but it's really important to understand the difference between an efficacy and an effectiveness study. And what we'll talk about here is the implementation science approach after efficacy studies have been implemented. Hybrid effectiveness and implementation science designs are really trendy right now. There's a lot of hybrid designs. I really like the hybrid designs as an epidemiologist because it can both address clinical effectiveness research and implementation research. And so there are hybrid types 1, 2, and 3. And at type 1, we test clinical interventions, really just to gather information on implementation. So any kind of clinical trial should be observing or gathering information on implementation to then lead to generalizability of that intervention. A type 2, on the other hand, tests the clinical intervention and an implementation intervention at the same time. So we'll look at not just the intervention, but also the strategy or who implements what where, and the effectiveness of that implementation. And type 3 tests implementation intervention more predominantly, and then also observes or gathers information on clinical intervention and outcomes as a secondary outcome usually. So here are some evidence-based interventions that you might know about. TB, 10 million new cases, 1.5 million deaths, 13 leading cause of death after COVID-19. And so in TB, there are different evidence-based interventions that have been used, including just basic ventilation in health facilities, medications that can be taken, and early diagnosis and treatment. So IPT and the BCG vaccine and others, and effective TB drugs, though newer drugs are needed. HIV, this data is a bit outdated, but there are about 1.4 million new cases in the last year and 600,000 deaths per year. Prevention, EBIs here are PrEP, so pre-exposure prophylaxis, which Kate mentioned earlier is one of my focuses of research. Male circumcision, condom use, and also treatment or use of antiretroviral therapy as prevention. And then treatment, evidence-based interventions, ARVs, and there's a lot of research going on and always improving antiretroviral regimens. So these are epidemiologic research versus implementation research. As I mentioned earlier, I studied epidemiology. I didn't really study implementation research, unfortunately. But when I came to do my research, I found that implementation research is really key to good epi. And so I would really say to anyone that wants to do epidemiology, they should also do this in line with implementation research. So in terms of outcomes, for an epidemiologist, we look at what health outcomes indicate improving health of populations. But implementation research will look at what implementation outcomes indicate improved quality of implementation. And the determinants that we focus on are risk factors, social determinants that affect the health, and implementation will then focus on individual, organizational, systems, contextual factors that affect the ability to implement well. Interventions and strategies here are the evidence-based interventions that can address these risk factors to then improve health of populations. And then for implementation science, we'll really look at evidence-based implementation strategies that can address these contextual factors. So these are some recent examples of misuse of ARVs and mosquito nets, which are evidence-based interventions. Smoking or using efavirenz or other drugs to get high, and some research in South Africa where there's recreational use of HIV antiretroviral medication. And on the right, you can see mosquito nets used for fishing nets. Where I lived in Mozambique, they also used mosquito nets for wedding gowns and other things. And so that's obviously a misuse of an evidence-based intervention. So you can have the best intervention out there, but if it's not used correctly, it won't improve the health of a population, obviously. So going into the components, there's two major components in implementation science. Applied implementation focuses on the tools and methods that are needed for successful implementation of the EBIs in healthcare and public health, whereas implementation research is the study of appropriate implementation methods. And the stages of implementation, as I explained in one of the first slides, can go all the way from exploration of implementation to sustained implementation, which is really our goal, our holy grail. Is that we want to see everything that's evidence-based have a sustained implementation and reach the people that need it. Some of these stages can take 2 to 4 years to full implementation. And so really need a focused strategy and framework to lead this implementation. So here are some implementation outcomes. As I mentioned earlier, you probably have heard of this before from the paper from Proctor et al. That really has guided a lot of implementation science. So the implementation outcomes here are the effects of deliberate and purposeful actions to implement new treatments, practices, and services, and are used as indicators of implementation processes and success. So in implementation, we talk about acceptability, adoption, appropriateness, costs, etc. In service outcomes, efficiency, safety, effectiveness, and in client outcomes, we talk about satisfaction, function, and symptomatology. So here is a list. I won't go all over these, but you'll be provided with the slides, and you can see what other terms are used and what the definition of it is for these various outcomes. And here as the different stages of implementation with the different outcomes. So in the beginning, when you're exploring an intervention, you'll look at, is it acceptable to the population? Is it acceptable to healthcare providers? Is it appropriate? Is it feasible? And then looking at costs. And then as you move on through the stages, through initial to full implementation, you'll look really more at adoption, fidelity, penetration, and sustainability. Fidelity is key. I think with any intervention, we want to focus on the adherence, compliance, integrity, or faithful replication of an intervention. And so within fidelity, we can measure the content, the coverage, the frequency, and the duration of the intervention. There's also determinants or factors associated with implementation. And this is also a good paper that you could read up more if you're interested in more determinants. Within implementation determinants or factors, we have individual, which are really patient and provider level, Also looking at innovation, organizational and structural and systems that then lead to the implementation outcomes that we discussed earlier. So the organizational determinants are key for when you're trying to implement an evidence-based strategy. And with us working in South Africa, working in clinics, this has been very key to our success of our interventions, is understanding the readiness for change. Is the organization, the clinic staff ready for change? Understanding the culture as well, especially as an outsider coming in, and understanding the climate, collective perceptions of their work environment and the implementation climate, really looking at the policy environment as well. So again, I won't go through all of these, but you'll have them in the slides, and you can see the different implementation strategies. Just to focus on one here, supporting clinicians, which is in the middle, is always key with any evidence-based intervention. Is an example of this is to facilitate a relay of clinical data to providers. And we've found this has been really key, is to feed back our clinical trial results to the providers, the nurses, midwives, the results of our trials, and to remind them about the impact of the strategies or evidence-based interventions, so that they can integrate it into their work. So now going into theories. A theory, again, is an explanation of how and why relationships between variables lead to outcomes. So a theory of change will be part of most of your work. It's a detailed description of how and why a set of activities will result in a desired outcome. A model is a simplified description of a process or phenomenon, and a framework describes a set of categories that may account for the observed phenomenon. And understanding and explaining these factors that affect the quality of implementation is key, and they provide really a roadmap to support the implementation process and evaluating implementation. When we classify theoretical frameworks, you can really have three different categories. So the first is really describing or guiding the process of translating research into practice, which are process models. Understanding or explaining what influences implementation outcomes, which are determinant frameworks, classic theories, or implementation theories. And then evaluating implementation, which is where we are now, and I'll use that in my example. And those really use evaluation frameworks. So to move on to mixed methods now, I just want to see if anyone has questions before I went over implementation science very quickly, but there's a lot of resources at the end. Anyone have questions that they want to mention? Okay, so there'll be time at the end as well. So mixed methods evaluation, integration is really a qualitative and quantitative research methods to explore, understand, and evaluate the implementation of health interventions. And the importance here is that it enhances the rigor and comprehensiveness of research and implementation science. So what I'm going to advocate for here is that we can't just do quantitative research or qualitative research alone. The two really build on each other and enhance the rigor of any study that you're going to be working on. Objectives of mixed methods is to understand the complex nature of health interventions, and it helps to both examine both the effectiveness and the contextual factors influencing implementation. So it's also really important to understand the uptake and the people's perception, both from the health provider side and the participant side, of why an intervention may have been effective. It provides a holistic view of the implementation process. And so here are some reasons for conducting mixed methods. I'm not going to go through all of them, but like I said before, it really improves the rigor of your research, so the validity, both to corroborate your quantitative and your qualitative data, to offset any weaknesses. No research is perfect, so everyone will have weaknesses, but I've found that any weaknesses in my quant data can be overcome sometimes with qualitative in-depth interviews or other interventions to draw on the strengths. And it's a more comprehensive way of doing research rather than just doing quantitative or qualitative alone. It's important to incorporate implementation science theories that I mentioned before to guide the evaluation. And these frameworks help to identify key constructs and variables for both qualitative and quantitative components. So here are some key components. The quantitative components will assess the intervention outcome, so usually your effectiveness of the intervention, and we utilize statistical methods to measure our impact. So examples of quantitative research include surveys, clinical data, pre and post comparisons. In a randomized trial, you'll have different arms where you compare the intervention. In a qualitative component, you'll really be exploring the contextual factors influencing implementation, both from the participant side, but also from the provider, the policymaker, and the other, the structural surroundings and the community around those implementing the intervention. And this will really provide an in-depth understanding of participants' experiences and providers' experiences. And examples here are interviews, focus groups, observations, but there's a lot of innovative qualitative work going on, including participatory methods and other workshops and other things. I've even seen photo workshops that people use, taking photographs and explaining their experience with an intervention. So you shouldn't feel limited to just interviews or focus groups. So the study design here can be sequential. A sequential exploratory design is a qualitative data collection and analysis followed by quant data collection and analysis. And the sequential explanatory design is a quantitative data collected and analyzed first. Sorry about the dogs behind me. Followed by qualitative data collection and analysis to explain quantitative findings. And the convergent design is a simultaneous collection of both qualitative and quantitative data with independent analyses. So the analyses might be collected at the same time, but they might have an independent analysis, so you're not analyzing the data together. So this is an example of an exploratory sequential design in a genogram project. In phase 1, they conducted a systematic literature review, which then built into qualitative interviews and analysis that built into the quantitative phase, online survey and analysis that led into the interpretation and further development of the app. And so this is really something that was a sequential design that started with qualitative, which is something that we did here as well in our formative work, is we did a lot of qualitative interviews to develop our intervention. And then we did qualitative again, so we kind of sandwiched qualitative after quantitative as well. The process model for embedding mixed methods here is to list your data as quantitative and qualitative and separate them out. Draw a diagram of your procedures and your application and consider where in the diagram you have the opportunity to collect both data and consider multiple points like I just explained in our study. Consider how you'll integrate the data. Will you merge it? Will you connect it? Or will they be separate data collections in your design? Employ the latest mixed methods. So there are new ways of doing mixed methods data, including diagrams, joint display, implementation matrices, including IDIs, in-depth interviews and focus groups. And then publish the study as mixed methods design. When you do this, you really want to involve stakeholders and participants in your design. From the beginning, you really want to think about who your participants are and get them involved. When you want to bring about this change and what kind of participatory approaches you want to use. So like I said earlier, these are the quantitative data and the qualitative data. Outcome measures and quant data are more health outcomes and behavioral changes, whereas qualitative data can include meeting minutes and implementation logs as well. So quantitative data, you could use descriptive statistics, inferential statistics, regression analyses, and implementation fidelity analysis. In qualitative analysis, you can use thematic analysis, grounded theory, content analysis, and constant comparative analysis. These are just a few of the different analytic strategies that you can use for a mixed methods analysis. So merging quant and qual results provide a more comprehensive understanding and improve the rigor of your research. They also illustrate how qualitative findings can enrich or explain the quantitative results, or vice versa, how the quantitative results can also enrich your qualitative findings. And the triangulation of data can really improve the validity and reliability of the data in your study. Some challenges, always have challenges in mixed methods or in any research, is really integration. For us, finding really when to integrate the qualitative, when's the perfect time to do the quantitative, and balancing the two components together. Also selection of who you select in your qualitative and not having a biased approach and selecting people that may have been had more exposure to an intervention rather than less exposure to an intervention. So really understanding who you're picking for your qualitative components if it's after the quantitative study. And then ensuring consistency between data sources, and then always time and resource constraints. Mixed methods, usually qualitative research will take more time, and it may be resource intensive, both from a human resource perspective, but also from an analysis. So adequate training for researchers in both methodologies is key. And sometimes your quant researchers cannot be your qual researchers. That's what I found. So a lot of the qualitative researchers need different backgrounds, training, and they may not be found among your quantitative researchers, unfortunately. There's a lot of advances in mixed methods approaches, and I'll give some links to some recent studies that you can review on your own. Incorporation of technology and data collection is really key. We're using AI now, so artificial intelligence, to help us with some of our analysis of our qualitative data. And we're getting ready to publish some of that to show how a human coder differs from an AI coder. That I could tell you that artificial intelligence coding was a lot faster and a lot less expensive, but it wasn't as accurate. But there are a lot of technologies coming out of the use of AI in analysis and collection, and then a lot of improved reporting standards for mixed method studies as well. So mixed methods and implementation science is key to understanding both the quant outcomes and predictors, as well as the drivers of change from the participant perspective, from the provider perspective, and understanding the uptake or the use of evidence-based interventions. Mixed methods can help to bridge the gap between research and practice and scale, and can also help improve the rigor of your study. You should all now embrace mixed methods, and I hope you will, for a more nuanced understanding of health interventions. So in summary, we have implementation science as an important field to maximize the benefit and impact of EBIs. And it's important to identify contextual factors that affect implementation, develop and test strategies to address contextual factors, especially implementation factors. And you could really think of these study design as tools. Choose a study design that will best address your research question. Remember, there'll be more than one study design, and it's really about bridging this know to do gap. And the mixed methods start, think about what you want to evaluate and apply a model to evaluate your research. There are some more resources. There's a free training that is available from the NIH on implementation science, more on overview of design, hybrid design, dissemination approaches, and mixed methods as well. Kate, I have time now for questions and answers, or I can go into a case study. So maybe let's take Q&A first.
Yeah, sounds great. Thank you so much, Dvora. Really appreciate this very kind of thorough overview. And want to just really encourage all of you to look at some of those resources she shared. They're awesome. If you are interested in implementation science and other pieces, you can do some more deep diving there. Let's open it up for questions. As people are thinking about, I'll go ahead and start us off, Dvora. So a large part of implementation science is understanding how things can actually be implemented in real world settings and sustained. I think you've done some really interesting work with this. I wonder if you can speak to some of what you have seen as the contextual factors that have either the biggest impact on implementation and are actually most amenable to change. So some of our kind of low-hanging fruit contextual factors that any intervention needs to address.
Yeah, great question. So a lot of the contextual factors are related to clinical delivery. So I work in clinical care in South Africa to improve HIV prevention and treatment among pregnant and lactating individuals. And so what we really sought to understand is really understand the contextual factors in the clinic and the policy and the guidelines that drive people's implementation of evidence-based interventions. So really, a lot of what we're talking about is training, training of providers, mentorship of providers, and development of guidelines. So in South Africa, like any context in the US, if you don't have CDC guidelines, no one's going to implement it. And so really having clear guidelines and making sure that they're evidence-based and that they're accurate and up to date. And so we've been part of developing the guidelines around PrEP use for pregnant and lactating populations here and making sure that they reflect what we found in our research, really from the top down, so from the National Department of Health on down. But once the guidelines are developed, people need to understand them and be trained on them and make it part of their work. And so really the training of providers and the mentorship of providers and supportive supervision has been really key. And so I think that any kind of contextual factors, you have to think about like you said, the low-hanging fruit is maybe you're going to work with a group of nurses and you're going to train them. But if the guidelines aren't there and the supportive infrastructure isn't there for them to implement this intervention, nothing will happen. It might happen for a few months for your study, but then it will be dropped. And so it's really important. Like I think it's kind of a sandwich effect where you're really thinking about the top level, the policy and the guidelines, but then also the integration of those guidelines in the nurses and the providers and making sure that they have the infrastructure, the education, and the mentorship and support to implement those guidelines.
Awesome. Thanks for that. I love the sandwiching approach. Any other questions? Shivani has one in the chat. Shivani, I'll go ahead and read this aloud. How do you decide how much time or resources to allocate for assessing the implementation outcomes, i.e. like re-aim factors versus the health intervention outcomes, such as your clinical outcomes? And then second piece there, when you publish data on effectiveness of a program, do you typically include your full analysis of implementation? So do you do a combined publication?
Okay. Yeah, those are great questions. And so I think for the first question is about time and resources, it really depends on the research design. And so like I presented at the beginning, if you have a hybrid design where your outcome, your health intervention outcome is equal to your implementation outcome, which is a hybrid type 2, you really will spend 50-50. You really have to spend 50% of your time focusing on the health outcome, 50% of your implementation outcome. It's really difficult to do. And what I've found in our ongoing work is that we had to have two separate staff, actually. One person focusing on the research, the health outcomes, the actual research implementation, and another person on the implementation, because it was so difficult for one person to do both. So that was a hybrid type 2. If it's a hybrid type 3, obviously you'll prioritize implementation science more and do less of the health outcome focus. And then a hybrid type 1, on the other hand, would really be a clinical trial where you're just kind of collecting implementation outcomes on the side. So we started out, I would say, with a hybrid type 1, where we really focus on a clinical trial, and a lot of our work was on clinical trial outcomes, which is all health outcomes. And we didn't think about implementation really at all. And I'm an epidemiologist, so that's my bias, is, I like doing clinical trials. But then when I realized that we'll have no sustainability after the trial if we don't think about all those contextual factors. Why do nurses do what they do? Why do doctors do what they do? Why don't, how do guidelines get drafted? All of that. Then I realized we really had to shift to more of a hybrid type 2 and understand the implementation. So it's really about your study design that you pick, and what kind of questions you want to answer and where you are in that continuum that I presented. When you publish data on effectiveness, do you typically include the full analysis of the implementation? No, no. I don't think, unless your effectiveness is an implementation science study, you really would just focus on the effectiveness outcomes as your primary outcome. And then maybe as a secondary paper, you could talk about the implementation process. And that's usually just because you want to be concise with your publications. I think it's better to have one or two key points than to have papers presenting all of your effectiveness outcomes as well as your implementation outcomes together. And so I would prefer to separate them out unless this is a real implementation study, and then you would focus on the entire implementation process. And it probably would go to a different journal as well. So your journal that you would select for an implementation type of study would be different than really your primary efficacy or effectiveness outcomes. So there's another one for, do you want to read it out loud or should I?
Yeah, I'll read it out loud. So Zach has a question, his mic isn't working. When coupling both quantitative and qualitative data, are there data collection methods that are preferred in the qualitative arm? Or should this align with general qualitative techniques, where certain methods for data collection are considered more robust than others? So thinking about when you're doing mixed methods, do you go with a classic in-depth interview, observational data? Does your decision change based on if it's mixed methods or not?
Yeah, I think it does. Obviously, it depends which one you're doing first, and so I don't think that there's a preference necessarily. But when we've done quantitative first and then qualitative. We'll use the quantitative data and our understanding of the quantitative data to drive our in-depth interview guidelines. And so we'll try to understand the quantitative and vice versa. We do qualitative first. So really you're analyzing that data first. If it's a sequential approach, you're going to analyze that data to inform your IDI guidelines or your focus group guidelines or your survey development, so that you're using that to have more robust data collection. For analysis, I don't think it really changes, unless you decide that you want to stratify by a certain group because of your quantitative data or something like that. You could do a stratified analysis, but usually the analysis techniques are the same. And I think that there's no method for data collection that's more robust than others. It's just, I think that it's better to use some foundation of quantitative before you collect your qualitative, because you'll have better responses. I don't know, Kate, is there any kind of technique you would use?
Yeah, just to add, I agree. I don't think your technique or your method would necessarily differ based on mixed methods or not, but your timing does, and the type of data you collect for within a survey or within an in-depth interview changes. One thing that I think is really helpful that we've started doing a lot of, if you're doing more of an epi or observational study or any type of experience, you use your quant data to give an overarching description of a situation, and it's fairly kind of high level, not super in depth. It could be around prevalence of a particular outcome of interest. It could be around potential disparities in outcomes. And then you use your qualitative data to deep dive into why, and kind of putting some flesh to the bones of what's going on there. And I find those to be quite impactful publications.
Mm-hmm. I agree.
All right. Any other questions? Otherwise, Dvora, we have about 3 minutes or so. Do you want to do the case study?
Yeah,
Or
I could do it quickly.
okay.
So just to share what we've done for, can you see my slides? So
Yeah.
we've done prep for pregnant and breastfeeding women. I just wanted to share our IS and their mixed methods approach. The background here I will go into. But when we arrived, there were guidelines from WHO, but no guidelines in South Africa, and the implementation of maternal prep remains largely limited to demonstration projects. And so in this demographic information, you'll see that there's no data on prep use in pregnant or breastfeeding women. In our study design, we started with a clinical trial that was an observational cohort of 1,200 pregnant and breastfeeding women. And then we evaluated who used PrEP and who didn't. And we used a convergent design of mixed methods that collects qualitative, so in-depth interviews with women and providers before and after the intervention, and then quantitative surveys over time. These are the inclusion criteria that I won't go into too long, just to show that we use this framework here to really understand what are we going to do? How are we going to integrate PrEP now that we've found that it's safe and effective? And we really wanted to use an evaluation framework. So the evaluation framework we chose was REAIM. And the REAIM is most frequently applied implementation framework. And you can see it evaluates the reach, effectiveness, adoption, implementation, and maintenance. And so what we sought to do to inform the policy and integration, we are evaluating the reach, effectiveness, adoption, implementation, and maintenance in this. And our aim and our implementation work now is to support the integration of PrEP into antenatal and postnatal care. And we continue to use a mixed methods evaluation that includes surveys, IDIs with providers, and policymakers, and women and focus group discussions with providers as well, that really came from our clinical trial to understand what are the facilitators and barriers to PrEP provision. And we've done all of this. We've done mapping, engaging the entire facility, training of all of the staff, identifying champions to help. And so we've trained more than 71 since this time. And so here are some of the contextual factors as we really found people were motivated. There's a high demand from clients, and the bottlenecks were numerous, including of HR, poor integration in maternal and child health, and then M&E bottlenecks. And so these are just an example really to show how we went from a clinical trial to an implementation science study using mixed methods. And so I'll share those slides with you so you have a bit more time to go through some publications from our studies.
Wonderful. Thank you, Dvora. Really appreciate your time. To remind folks, Dr. Dvora Davey is faculty at UCLA and joint appointment at University of Cape Town in South Africa. Nafisa is working with Dvora now, and Dvora supports a lot of our students as well as students from UCT and surrounding institutions. So if you are interested in this combination of epi and clinical trials, PrEP, and actually PrEP is one of multiple things that you focus on, Dvora is a great person to talk with. All right, thank you. We're going to transition now. I am excited to introduce to you Dr. Saad Saeed. He is the new director for the Global Health Program, effective, I believe, last week, newly joining the team. And he is currently in Boston, but will be in Los Angeles soon, and you guys will be seeing a lot more of him. So I want to turn it over and let him introduce himself and welcome him to our program.
Thanks, Kate. I appreciate it. Good morning and good afternoon and good evening to all of you. I know I've met a couple of you, either virtually or in person, over the past year and a half through the process of making the decision to come to UCLA. I'm really, really, really excited to be with all of you and to join what I think is a fabulous program for students to really immerse themselves in learning a lot of different aspects of what it's like to work with populations that lack a lot of resources often that we take for granted, and to try to think about delivering healthcare more equitably around the world and in our own backyards. And just want to say thanks to the team for inviting me today, and I just really look forward to being with all of you and learning with all of you, and helping in any way I can to make sure that your experience as a medical student and beyond is excellent and sets you up for success, and however you choose to define it, hopefully in the field of global health and specifically equitable healthcare delivery, again, defined anywhere and everywhere in the world. If you guys don't know, I'm just by way of background, I'm a neonatologist by training, and I will maintain a practice at Olive View Medical Center, which I'm really, really excited about. Won't be a ton of my time, but enough to keep me honest as a clinician. And also happy to talk to anybody about the field of pediatrics and neonatology, or really anything that has to do with child health care. I've got a lot of passion for it, and I have a lot of friends and connections in that space. So happy to introduce any student that's interested in that specifically to folks that I know, and provide mentorship specifically in that clinical area to any of you. As Kate said, I will be back and forth between now and June, just because of the timing of the transition to the directorship. But I'll be in LA every month, pretty much, at least for a week or two. Absolutely look forward to meeting all of you in person. And as I told Kate and Tracy, I'll be a regular participant in our, I think, monthly or bi-month, I think it's monthly meetings with all of you. So I'll get to know you guys at least virtually for the next few months, and then again, more in depth when we're in person. And also, all of you should feel absolutely welcome to reach out to me directly. You don't have to go through any funny channels. I have a UCLA email now, the MedNet email. It's S.Saeed. I'll put it in the chat, at blah, blah, blah. But you should always feel free to reach out to me. And I think I've already had one conversation with Nafisa about me reaching out to you guys too, specifically. I'm going to recruit some of you if you're interested in helping us to think about the evolution of the medical student curriculum over the next few years, what we should be focusing on, what we are focusing on, and just always thinking about how we can improve what's already a really excellent set of learning opportunities for all of you. So I'll end there because I know we've got some time to do some focus groups, which I'm excited to participate in too. And I'm actually happy to take, I don't know, Kate, if we have time, I'm happy to take a question or two if something's pressing. Otherwise, happy to just move into the focus groups.
Yes, we have time. We have like another 5 minutes or so. Any questions or thoughts to welcome Dr. Saeed? Sad, I wonder, can you also give just a little bit of background on your experience with global health? So clinical training, all those different pieces.
Yeah, that's great. So, sorry, I should given him more of a background. So I've been working in this space for over a couple decades in a lot of different capacities. I started off in residency at UCSF, working with a colleague of mine who's now actually the head of Peds ID at UCSF, a great guy, Ted Rule. We started a nonprofit, and it was really just focused on education and training in a couple of places, one in India and one in DRC, just community hospitals in the rural parts of the country that we had personal connections to, and that were interested in having just more of a teaching, training, learning opportunities around pediatrics. That segued into a couple of decades of work at Harvard, and again in a lot of different capacities, primarily focused on education and training of clinicians in countries that have suffered from pretty severe and critical a shortage of healthcare providers across the board, from nurses to midwives to doctors to pharmacists to lab techs, and so have been involved in a lot of different projects that are focused on trying to increase the absolute number of providers, and then also improve the quality of education that they're receiving. And it's a complicated space and doesn't lend itself to simple, easy fixes. It's very much a long-term effort, and a lot of it comes down to just getting these places a lot more resources, but have a lot of experience, particularly in Africa. But I've worked in like I said, in Asia, in the Caribbean, in Haiti, and so have experience in a lot of different settings, and a lot of different um, challenges, and have done a modest amount of um, writing and research and scholarship, but I'm nothing like Dr. Dvora or Kate in terms of expertise when it comes to implementation science. So this was actually wonderfully edifying for me too to listen to, and um, uh, just want to say again thanks to all of you for having me.
Thanks so much. We're really excited to have you. And just to echo, please feel free to reach out at any point to Dr. Saeed, like you do to Tracy and myself. I am really excited that we're becoming a multifaceted, larger faculty team for you, and that provide very different areas of expertise. So please feel welcome to reach out. And yeah, we look forward to having him on our calls more often. Okay, great. So before we split up into our small groups, I want to cover just a couple housekeeping things for everyone on the call. So first, just as a reminder, your WordPress reflections are due on the 15th. Thank you, Zach, for correcting me on that date. So that's January 15th. Everyone should have access to the WordPress. And a reminder for Discovery, you are writing your reflection and you're also responding to two of your colleagues' reflections. So this is this is working to build community and ensure that we are engaging with each other. Because I think we have a lot to learn from each other as we're having different experiences around the globe, but as well, just different ways that we reflect on experiences that we have. So that's WordPress for January 15th. The other piece is for the clinical case studies. So in February, we will be starting clinical case studies, and Dr. Gallup will be joining us for those to lead you through. If you are interested in presenting a clinical case in February, that is due this month. Oh, I believe that is also due the 15th.
Due the 12th.
Thank you. I'm not sure why we had two different dates. We'll streamline in the future, but yeah, the 12th. Submit those, and then Dr. Gallup will reach out to whoever's selected to present their clinical case. Last thing is I want to just make sure everyone is being able to use your box well. So Dr. Davey's presentation will be in your box, as well as the recording for last month's panel discussion on communication. And we're adding more and more resources there as things come up. So welcome to my messy desktop. I want to just make sure that we all are on the same page of where this is. You should have in box a class 2025, your cohort, and you should see here various folders with resources for you. Dr. Davey's presentation, we will put here in presentations. So you'll see that here today or tomorrow. And then we have this whole new added section for tools for outputs or dissemination. So I sent you an email with some of this, but this kind of tips for publication, breaking down the type of articles, and some different strategies that I think have worked well for medical students in the past of writing either commentaries or letters to the editor, and then your primary paper, and then getting engaged in secondary papers with others is kind of a nice setup. So you'll find that here, as well as resources for how to write, selecting journals, and other pieces. Okay, any questions? Zach has a question. Okay, Zach, I'm going to read your question aloud. There's a lot of residency-related, sub-related events occurring right now at DGSOM. Not all of them have been recorded, making it a bit difficult for those of us in incompatible time zones. Is there any chance we can ensure that these residency-related materials are recorded? Great question. We have struggled to get things within the Hills curriculum recorded, as you guys know in the past. But absolutely, we'll reach out to the Heels folks and see exactly what's happening and how we can ensure that you have access to materials, because if there is, residency related pieces, that is important for you. We'll also, we need to also make sure that all of you are set up for your, that all of you are set up for your re-entry into clinical rotations. And so I know that all of your general rotations for May are already set up. If you want to do specialty rotations for your May intensive clinical re-entry to LCEs, that is something that for you to navigate with faculty at UCLA. So I think timing wise, we had said in February is the time to start thinking about that. And we'll have Talia come back and be able to talk to you about that. Okay. Anything else? Great. Okay. Then we will go ahead and split up into small groups and just have our usual discussion on how your month has been, your goals for this next month, and strategies for success. Great to see all of you. As always, please don't hesitate to reach out and talk to a small group of you here in a sec.
Alrighty, so it's the same as it was last month. If you are not put into a breakout room, you will stay in the main room with me. And let's get started. Hello, ladies.
Hi.
Hi. How's it going? I love how Em and Mika look like me as well, because we're in the 6 a.m. lifestyle at this moment in time. You guys are in the evening, afternoons, and we're in the 6 a.m. lifestyle.
Yeah, but Vegeta, it's rude of you to look so good.
Oh,
We all
no,
need to
trust
sign a
me.
pact beforehand that you're bringing it down. You're messing with the curve, Vegeta.
No. Do you see this? This is my pajama top. I'm like trying to cover it because I'm like, wait, let me stop recording. Look at me.